When are GPs going to return to pre-COVID levels of seeing patients face-to-face?
Okay, they're not.
Good. I mean, sorry.
So I know this is really difficult because both GPs and patients often want personal care and often believe that the only way of having really personal care is being in the same room as your clinician. And I understand that, but actually there's lots of people who don't want to be in the same room, who find the increasing remote care to be highly convenient, particularly people who have working responsibilities, care responsibilities. We're seeing a growing number of particularly adolescent boys in general practice that we never saw before when they have to come into our health centre. So there's lots of advantages to remote care, and it feels to me, as I described, that a shift from 80% face-to-face to 60% face-to-face as a consequence of what we've learned during the pandemic is probably about right. And I've got a sneaking feeling that in a year's time, this argument will have gone away, and maybe even the Daily Mail will apologise. No, I doubt that.
Okay, so there is a long history of continuity of relationship between patient and doctor, and people still talk about my doctor, my family doctor. Increasingly, the models that you describe with larger practices, GPs with particular skills and so on, does that continuity still exist in that new model, do you think?
It certainly exists far less than it used to do so, and that's a consequence of a number of factors. Both factors amongst patients. Patients are less likely to be in the same geographical area, they move more. Doctors also often want to be more mobile. Doctors increasingly, as I've described, want to work part-time. So I think there's a range of reasons why continuity is less than it used to be. But I don't think that the models that I've described of both increased scale and increased multidisciplinarity have to dramatically change the nature of continuity if we design continuity of care into the way that we deliver services. And some of the large organisations and multidisciplinary organisations are now looking at continuity as not being one patient, one doctor, but one patient, one micro team. And a small team of perhaps 2 doctors if they're working part-time, and a nurse and a receptionist can provide really personalised care. And I think it's really important that we in general practice understand the advantages of doing that, because the research evidence around the benefits of continuity is really convincing. So we know that if you provide relational continuity for patients, not only do patients have a better experience, they're more satisfied, not only are they more likely to comply with medical advice, they're more likely to get better disease outcomes, and they're even, amazingly, less likely to die as a consequence of continuity of care. And we also know for clinicians, you have a much higher level of job satisfaction if you're seeing the same patient and know the patient and are able to build on from one consultation to the next. And then probably most importantly for policymakers, although they haven't got the message yet, despite our efforts, it's really good for the NHS as well. Seeing people in a very fragmented way is a very expensive way of delivering care. And often a very inefficient way of delivering care. And we know that patients who experience good continuity of care are less likely to go into emergency departments, they're less likely to be admitted to hospital, and the overall healthcare costs are much less. So the research evidence is really strong. So you're right that it is at risk, but all of us need to work to maintain it.
Is it to some extent also enhanced by the increasing ability for a clinician to see more than one window, as it were, on the patient when the consultation happens? If you can see the interaction with a range of services rather than just the one in front of you, does that to some extent enhance the continuity rather than detract from it?
Yeah, I think it would do. I think it's really important that we do that, because part of continuity is about integration of care.
Yeah. So one of the questions I'm getting quite a lot of numbers on, so I'm going to have to put it to you as sensitively as I can. Quite a lot of folks are saying that they are seeing increasing number of patients who've had missed diagnoses. What would be your perspective on that? Yeah.
So I don't think we can argue with the data. We know that there have been delayed or missed diagnoses. I mean, the question is, what is the cause of that? And all the data that we've looked at, although there are anecdotal stories of GPs missing diagnoses because they haven't examined a patient, the vast majority of the causes of delayed diagnosis are a consequence of patients either not turning up to their GP, particularly during the height of the pandemic, where they were told stay away, essentially, protect the NHS, or because they were frightened about picking up infection, or because they wanted to protect the NHS. So there are a lot of patients, a lot of the, at one time, the number of cancer diagnoses was down 70% at the height of the first wave of the pandemic. A lot of that was a consequence of patients not wanting to come in, and that's why we as a college and NHS England tried to put out very strong messages about the importance of if you think you're sick, please come. That's really important. So that was one cause, and the other cause was, although again it isn't always accepted or admitted, a lot of the services that we referred to just shut down.
Yep.
Particularly again during the first and second wave of the pandemic. So it was really quite difficult to find the services even when you felt something was going on. So I'm not for one second suggesting that everything has been perfect in general practice and that the shift to remote working hasn't caused some challenges, but it's far from being the primary cause.
Do you have any sense of scale? I mean, I've heard numbers suggested of around maybe 50,000 missed cancer diagnoses as a consequence of COVID. Does that feel like, from your academic work as well, the kind of numbers we're thinking about?
I think it's really difficult. We simply won't know until time plays its way out, and we're able to look in a time series at the number of diagnoses that are made over time. It might be right, and the consequences are enormous, aren't they? If that is the case.
Absolutely.
Not just cancer diagnosis, of course, but dementia diagnosis and a whole range of others as well.
Absolutely. I want to move on to some other questions we've got here, which are more about the kind of how we do stuff together. I've got a question here, which I have to admit I don't understand, but 11 people do, so I'm going to ask it, and perhaps you can explain to me what the question means. So the question is, do you see a role for credentialing in palliative care for GPs with partnerships with RCP, RCGP and hospices to address a future skills gap? I can't even say credentialing.
Credentialing.
Thank you. You can say what does that mean?
Whoever asked that question, are the mics on? Can they come and just...
The mics are on, but 11 people have liked it, so...
This is somebody who either initiated it or liked it. Could you explain? Because
Sam. It's somebody called Sam.
Credentialing is a formal activity that's done by the General Medical Council.
Do you want to speak to us, Sam, or do you want to remain anonymous?
Okay, let me have a go. Nobody wants to be brave enough to own that question, do they? Let me have a go at answering it. Credentialing essentially is an extra level of training and an extra level of qualifications to allow you to deliver better quality care. I have mixed views on it, I have to say. The training that we do as GPs is training that allows us to be generalists. Allows us to address lots of clinical problems and the interaction between lots of clinical problems, and to bring the clinical problems, the medical problems together with the social and psychological and spiritual problems as well. It's an intensive training in and of its own right, and I don't know anybody who's become a GP who really wishes that they were a specialist. They become a GP because we like people and we like whole person care. That's why we do it. So there's no shortage of specialists out there or specialist bodies out there who say, why don't GPs do more training in X, in blah, and whatever it might be. And there are GPs that want to have an extra set of skills in order, for example, to do palliative care, and I have no problem with that. But the suggestion that that all GPs should, or that you should only be able to provide end-of-life care if you've got credentials, I think is a misunderstanding of what general practice is about. We bring the generalist skills. If we need specialist skills, then we work as part of a team in order to provide that. So I hope whoever Joe is happy with that.
Yeah, I think Sam must be happy because he's not responded so good. So a question that's sort of has come to me in 2 or 3 forms, but basically what it boils down to is what can hospice locality teams, particularly those aligned with primary care networks, what else can they do as hospices to support primary care colleagues, do you think?
So, in my experience, it's the accessibility into the hospice set of skills that we really need in general practice. And in some parts of the country, that's not a problem. In other parts of the country, hospices, like other parts of health and care services are really struggling. So if we can get really good access to the specialist skills that are contained within the hospice movement, then that's primarily what we need. Now, there are many reasons underlying difficulties with access, but that's primarily what we want. And sometimes, as general practice teams, we need a patient almost to be taken out of our responsibility for a short, limited period of time, to give everybody in our team a break, if you like. And where hospices are able to provide that kind of respite services, that's really helpful too.
Okay, so I have to say, in terms of the questions, both the volume and the quantity is far greater than any other session I've been in. People are really keen, very keen and interested in this, and have got some strong perspectives. One here, this one you'll like. A young GP works 1 day a week in my hospice. He's very demoralised by criticism of GPs, Daily Mail, family acquaintances. The stuff about you can never speak to your GP, etc. How do we keep him motivated and help him? What can I do to perk him up?
Yeah. Well done for employing him for 1 day a week to do something different. General practice is a really difficult place to be at the moment. You need to be a good GP. You need to have high morale because it's a really demanding, difficult job. You need to have a high level of self-confidence in order to be able to make the decisions. When I talk about seeing 50 or 60 patients a day, each one of those, even the simple ones, I have to make a risky decision. It might be, do I sign this prescription? Do I not sign this prescription? Am I at risk of missing a diagnosis or delaying a diagnosis? Every single decision that we make is potentially risky and increases the sense of anxiety that clinicians have. And the problem with the criticism that we're seeing, and indeed the abuse, the abuse is growing as well, and it's really scary. A BMA survey suggested that 20% of GPs had personally experienced abuse, not as bad as the machete attack in Manchester, but they'd personally experienced abuse, sometimes physical abuse. And 50% of GPs said that they had seen abuse to members of their team, to members of their staff. Just the other day, a GP contacted me saying that a father of a young girl who had simple uncomplicated conjunctivitis was demanding a face-to-face visit. The diagnosis was very clear and very simple. It's the kind of diagnosis that you can make over the telephone. The father was demanding a face-to-face visit. The GP didn't think it was necessary, so the father came in and barged into the room, threw the patient out who was in the room, and locked the door, sitting down with this young female GP in order to demand that the female GP saw her daughter. And that kind of thing, really has a massive impact on our ability to do our job and our ability to carry on doing our job, our ability to recruit bright young doctors into general practice. We need the very brightest of medical students coming into general practice. It really is a massive challenge. So that's why every time we hear the Daily Mail, occasionally the Daily Telegraph, I'm not just picking out on those, there are others as well, criticising general practice, we're continuing to push back. We try not to do so in a defensive way, we try to do so in an active, positive way, but we have to push back on this criticism because that is what a lot of people are citing is causing them to go part-time or to retire early. So it's a real crisis.
Thank you. I'm really conscious of time, so I'm going to ask just one more question. I'm sorry I've not been able to pick up all the questions we've had, but we've been really snowed with questions, which is fantastic. And we do make a record of all these, so we know the issues after the conference that people have been raising. You said, Martin, earlier on that when the NHS was created, it was created in 3 silos, one of which is primary care. Somebody here is asking, it's quite a popular question, what will it look like in 5 or 10 years' time? I'd put a bit of an edge on that question and say, isn't it time just to change the model? Take the silo, mash it in with acute care and make it all one thing?
Yeah, so it's a really good question. You look at some models around the world of integrated care, particularly Young Shipping in Sweden. There's some really good integrated care systems in Israel. Even in the States, where some of the isolated care systems are highly integrated. What you see is, if you measure it, 20% better care for 20% lower cost. So integration is really important. The challenge is how you break down the long-established historical silos. And my answer to that is quite simple. It's nothing to do with structures. It's nothing to do with, well, it's a bit to do with funding arrangements. If you have a common budget, that helps. It's entirely to do with the way that frontline staff, both health and care staff, work together. And the best examples that I've seen of integration are where staff from across the NHS sit down with social workers when they're necessary, with care staff, sit down with patients in a team and redesign care pathways. And when you do that, all of a sudden, from a patient perspective, you start seeing where the fragmentation sits. And if across the whole health and care system, we work with patients to redesign care pathways, that is what would make the difference. Which is why I said I was slightly sceptical about the health and care bill. You know, it provides a kind of, it's a bit of context, which will help a little bit. Probably no more than the other, I think it is 12 major policy initiatives of the last 20 years to integrate care, but it'll help a little bit. But what really matters is people working together on the ground from a patient perspective. That's what needs to be done.
Great. Thank you, Professor Martin Marshall. Thank you very much. And thank you to all of you for your questions.